in this PowerPoint, we're going to review this shift from medical paternalism to principlism, and we're going to look at what exactly are the Belmont principles. As we go through this PowerPoint, I want you to focus on the shift from paternalism to principlism. And I know we kind of went over this briefly before, but we're going to look in more depth into what was paternalism, what was the purpose of paternalism, and then why did this shift to principlism occur, and what does this shift mean? It is very important that you can understand, define, and apply the concepts of autonomy, non-maleficence, beneficence, and justice. As with all of our ethical theories, make sure that you know how to describe how principlism answers the three big questions of ultimate reality, human nature, and the role of God. Prior to the 1960s, healthcare ethics really focused on the role of the provider or the physician, and healthcare ethics was deemed medical paternalism. The foundation of medical paternalism came from the Hippocratic Oath, and the real attention for healthcare at this time was based on the care the provider offered and the outcome for the patient. The focus was not patient-centered in the sense that it wasn't focused on the individual needs, preferences, or rights of the patient. You could say, in a sense, that healthcare was very much a standardized algorithm. Medical paternalism is often defined as the physician's prerogative to act in a manner that he or she deems to be in the patient's best interest. So in other words, the physician was providing ethically appropriate care as long as they were doing what they deemed to be best for the patient. The purpose of medical paternalism and the Hippocratic Oath was to demonstrate how solemn this commitment that the physician had, to demonstrate how sincere this commitment to do the best for the patient was. Furthermore, the Hippocratic Oath and medical paternalism brought together this connection between medicine, spirituality, and religion. Medical paternalism can be broken down into three primary principles: beneficence, which is doing what's best for the patient; non-maleficence, do no harm; and confidentiality, protect the privacy of the patient. There were three primary assumptions within medical paternalism, and those assumptions were that the physician would always act in the patient's best interest, the patient would agree with the assessment that the physician provided, and both the patient and the physician would agree that the physician knew better than the patient what was best for the patient. Some of you may already be starting to think about the limitations of medical paternalism, specifically this concept that the physician was the one who knew what was best and that the patient did not question the physician. Historically, under medical paternalism, the physician is who defined harm and good and carried out what they believed to be this patient's self-interest. The patient then was ignorant, and I don't mean ignorant in a derogatory term, but ignorant of the fact that of what the physician was doing and what their treatment was. Some of you may be aware of the time before the electronic health record, and you may remember a time where you did not get a detailed summary when you left the doctor's office. You got a paper prescription to bring to the pharmacy, and maybe you got a list of your vaccines, and that was pretty much it. The patient could not, at their fingertips, access all of their results. Furthermore, autonomy was not part of the Hippocratic tradition. If you recall, that was beneficence, non-maleficence, and confidentiality. If we look at the American Medical Association's first Code of Ethics from 1847, nowhere in that Code of Ethics is autonomy mentioned. We've been talking a little bit about the changes that took place in the 1960s. And really, those changes made medical paternalism outdated. Patients started to see themselves as being partners in their own care. Patients wanted to be more involved and more knowledgeable about what was going on with their care because it was their bodies and they wanted to have a say in how they were treated. And that brings us to the introduction of patient autonomy and the Belmont principles. So, to look a little bit more deeper into this transition, if you remember, medical paternalism focused on outcomes, not the patient needs or wants. And paternalism sounds like paternal, father. Basically, the healthcare provider was acting in the role of a parent, and the patient was a child and did what the provider said. In the 1960s, this focus changed to be on the relationship, and the idea was that the ideal physician was democratic, and that ultimately the choice of medical treatment and if treatment should be provided belonged to the patient themselves, which led to the development of the Belmont Report, which we discussed in week 1. It was drafted by the philosophers. It was made devoid of religiosity. It was objective, nonpartisan, and it was based on philosophic ethics. So therefore, the Belmont Report would not have been grounded in divine command theory, because the Belmont Report really wanted to separate healthcare from religion. And if you remember, part of the Hippocratic Oath was uniting this knowledge and wisdom with religion and spirituality. And the Belmont Report said no. The author said no, we don't want to do that. We want to keep theology and religion out of this. Initially, the Belmont Report was developed as a guideline for autonomy related to human experimentation. So we're going to look again into the Belmont Report in a little more detail. So, an overview of the Belmont Report. The primary responsibilities for the Belmont Report was that the duty of the physician was to the patient. And really, we could think of this as not just the physician, but any healthcare provider. Your duty was to your patient, and your responsibility of the state's responsibility was to protect its members, so to treat each person with dignity and respect. Patients then were defined as anyone who could have a medical condition for which they would seek professional treatment or advice. So anybody who sought that treatment should be treated with duty and respect. Providers were no longer merely physicians. Providers was anyone involved in the patient's treatment. So this could be a researcher. This could be someone in HR. This could be someone in finance. It could be leaders, managers, not just doctors. It was other people clinically, the nurses, the phlebotomist, the respiratory therapist. And the three guiding principles initially were autonomy, beneficence, and justice. Non-maleficence was then added because it originally was thought to go under beneficence. The idea of doing what's best, do no harm, should go under it. But remember, we pulled that out then. And you will sometimes see the Belmont principles or principlism listed as 3 or 4 main principles. We're going to consider it as 4 moving forward. With these principles, no one principle was to overrule another. Each principle was to be considered binding unless a principle came in conflict with other duties. And then you were to rationally calculate which duty was higher in that circumstance. So a lot of times you might have seen this conflict, especially between non-maleficence and autonomy, or beneficence and autonomy, because what the patient autonomously wants, the treatment or lack of treatment, may be harmful or may be leading to harm. So now we're just going to take a couple of minutes and focus in on the components of each of these 4 principles. The principle of autonomy is very heavily grounded in Kant's ethics. And if we think back to Kant's ethics, we really want to focus on the principle of humanity and the principle of reciprocity. The principle of humanity said that we always treat others as ends in themselves, never merely as a means to our own end. So we don't use others for our own personal gain. The principle of reciprocity talked about treating others as we would want to be treated. Autonomy was then defined as the concept that people are free to perform the actions they choose, even if others deem these actions to be foolish. Therefore, autonomy was a function of human free will and the ability to exercise your free will. The purpose of the principle of autonomy was to safeguard the free will and free choice of the patient, because the Belmont report was really pushing for the patient to have a say in their health care. Conversely, which some people are not as aware of, autonomy protects those who are not mentally able to make choices. So autonomy protects those who are minors and too young to make a competent choice, or those who have been deemed medically incompetent to make choices on their own, so that you don't have, say, a 5-year-old declining medical care because they're afraid it would be painful. There is somebody who speaks on their behalf. In the case of a 5-year-old, the parent. In the case of an adult that is not mentally able to make decisions, either the state makes decisions or there is an appointed guardian. The other purpose of autonomy was to liberate patients from physician oppression so that the patient had an equal say. There are some moral limits to autonomy. As I discussed previously, no principle should supersede all the other principles. So autonomy was not an absolute right. There were the natural limits of health, safety, welfare, and the rights of others. So you have this free will as long as you are not infringing on the health, safety, welfare, or rights of others. A great example of this would be during the COVID-19 pandemic. A lot of buildings did not allow people inside who did not choose to wear a mask. Hospitals were one of those buildings. You could not get in without wearing a mask. Tuberculosis is another example. Tuberculosis cases are mandatory to be reported to the State Department of Health, and individuals who are diagnosed with tuberculosis have to go to the Department of Health to take their medication so that compliance can be monitored because the disease is so contagious. This is to protect the health, safety, welfare, and rights of others. Autonomy has both secular and religious appeal. From the secular angle, autonomy is fundamental to democracy. It is fundamental to this concept of focusing on the individual and limiting the say of the government. On the religious appeal, autonomy is fundamental to the freedom of consciousness and expression and the freedom to be able to choose to follow God. Under autonomy, we need to overall respect the decisions that the patient makes, even if we deem those decisions to be foolish. And this can be really hard for healthcare providers who feel that a patient is making a decision that is not in their best interests. However, we have to remember that if the patient is competent to make that decision, then while we may morally disagree, we have to be respectful of their choice while still showing them compassionate care. All right, so we're going to talk about autonomy in healthcare. And when we talk about autonomy, we want to look at coercion, competence, and harm. So we're going to start with coercion. And you may have heard the term coercion before. Coercion refers to this concept of trying to please someone else and hiding your true or real choices or desires. So coercion is basically meaning that when you make a healthcare decision, it is not truly an autonomous decision. You are making a decision because you are trying to please somebody else. You are making a decision based on what you think they want you to say or what you know they have told you you are to say. So this may be the person who's making a decision because they want to do what their spouse would want. Or it's an older person who's trying to follow the desires of their child. We also worry about coercion in abuse situations, and is a person refusing treatment because they've been told they're not allowed to receive it? And are they making that decision only because the person sitting next to them is saying that that's what they want, or is trying to force them or have a say in their decision? Coercion can be other things as well. So coercion could be anything that's going to compromise your decision. So coercion may be that you don't have the finances to pay for something. Coercion may be that you don't have the way to get to the treatment. So as healthcare professionals, we need to consider what might be compromising or coercing a person's decision. Is this the true autonomous decision that they would make if nothing was standing in their way? Or is there something standing in their way preventing them from making the decision that they truly believe is best for themselves? Competence. Competence really refers to your ability to make an informed decision about your care. And sometimes we usually think of competence in a general sense of, oh, this is a competent person. You may say, oh, this person is college educated. This person is literate. This person speaks this language. They must be competent. But what we really want to look at is specific competence, which is the ability to understand and perform a given task. So you want to look at right now, is this person competent? And there's some things to consider. Somebody may be intermittently competent related to a medical condition. So an example of this would be maybe you're the finance person for the hospital and you come in to talk to a patient about their finances. But the nurse just gave the patient morphine, and morphine tends to make people confused and groggy and tired. They're not competent to have a discussion with you about their finances right now because of the influence of the morphine. Another thing that makes people incompetent would be their age. Minors are not competent to make a healthcare decision. So as much as that 5-year-old tells you he does not want a shot, if mom and dad say he is to have the shot, they're making the decision as his caretaker on his behalf. And we're not going to get too into that, those specific situations, because that's a little bit beyond the scope. But the idea is that this person is competent to make a decision. The other thing is that they actually understand what you're telling them. And I think about my dad with this. My dad is a college-educated man, worked for the Department of Defense in the military for many years. However, my dad sometimes doesn't understand what the neurologist is telling him. And there's been times where he has asked the neurologist to call me and explain it to me because I'm his medical power of attorney, so that I can also then talk to him about it and help make sure he understands what's going on. So as healthcare providers, we really need to look at what we're specifically asking somebody about and if they understand it. So we are gatekeepers for determining competence. And the good thing is there's some specific standards and tools that we can use to help determine somebody's competence. And sometimes competence has to be determined by a judge. And you see this a lot in mental health, where a judge and a psychiatrist will work very closely together based on a patient's history to determine if they're competent to make their own decisions. Finally, with autonomy, we consider harm. And this is sometimes where autonomy and beneficence and non-maleficence butt heads. And under autonomy, the patient owns their life. The patient has the final say, and we cannot force a competent patient to take a treatment that they are refusing. However, a person who is deemed incompetent cannot make an autonomous, informed decision. So, what do? There's pretty much two main options. The one option is substituted judgment. And these are things, usually it's a written document such as a living will, advance directive, DNR order, DNR order, and that is at the time when this person was competent to make an autonomous decision, they indicated what they would want. A great example of this would be going into surgery and somebody who is a Jehovah's Witness and does not believe in receiving blood products signed a form when they were competent before they went into surgery that if something happened, they did not want to receive blood. Therefore, they're under anesthesia now. They are unable to provide consent. They are not competent, but we know not to give them a blood product because we have a signed document from when they were competent, so we can use substituted judgment to not give them the blood product. The other option is acting in the best interest, and that's doing what a reasonable person would want done in this situation. And we do this a lot if somebody's not competent and they're a John Doe. I've also see this a lot working in the ER, especially in the summer when there's summer camps. Great example, had a little kid got stung by a bee, was having an anaphylactic reaction, meaning kid couldn't breathe. Camp counselor brings them over to the ER. I am not going to wait to get mom and dad on the phone to get permission to give this child epinephrine and to support their breathing. I'm going to assume that a reasonable parent would want me to save their child's life. And that's what we did. Now, we still worked to get mom and dad on the phone. Somebody else did that while some of us performed life-saving care. And usually you're going to see best interest enacted during terms of life-saving care or with a John Doe patient where we can't get a hold of anybody who may be able to provide substituted judgment through a document or even saying this is what they had told me or I'm their appointed person. And we'll go into that a little bit The next principle we're going to talk about is non-maleficence. While non-maleficence was part of medical paternalism, I do want to note that this did not come from the Hippocratic Oath. And many people, when they think about the Hippocratic Oath, they think about the doctor making the oath to do no harm. This was not actually a part of the original Hippocratic Oath. Non-maleficence really came out of the Nuremberg trials following World War II because of the concerns regarding human experimentation that were conducted by the Nazis in Germany and by Gregor Mendel. So, as I kind of alluded to, non-maleficence means do no harm. Maleficence is harm, so non-maleficence is no harm. This applies to both acts of commission and omission. So this applies to do no harm by the choices that you make, and also failing to make a choice that results in harm is violating non-maleficence. Originally, the purpose of this principle was to protect research subjects and to protect against misguided utilitarianism. Because prior to World War II, and sadly even following World War II, there were a lot of research projects that were conducted that exposed individuals to unsafe, unfair conditions without their consent, under the guise that doing harm to a few would provide the greater good for many. An excellent example of this would be the Tuskegee experimentations, where African American men were injected with syphilis without being told exactly what was going on, and were not then provided with the best treatments available. Some very important legal aspects of non-maleficence for all healthcare providers are the duty to care and medical negligence. Duty to care is that you should perform care at the same level that a reasonable person who has your same qualifications, education, licensing would provide. Medical negligence, in contrast, then, is failure to provide this due care. Non-maleficence is a very important ethical concept today, and we see this a lot in healthcare systems when we look at patient safety, employee safety, and specifically tracking medical errors. The focus used to be for medical errors on the individual and what they did wrong, and holding the individual responsible for medical errors. We're now looking at medical errors from the mindset of a failed system. And where did the system fail? Where was there an act of commission or omission within the system that led to the poor outcome? We also see non-maleficence played out today with the quality of care in nursing homes and making sure that patients in nursing homes are receiving due care and that they are being treated with dignity and respect. I wanted to take a minute here to really focus on defining harm. And harm is broadly defined as that which worsens the condition of the patient. And sometimes I think when people think of harm, they think of pain, they think of physical immobility. And just because something causes a patient pain or physical immobility does not necessarily mean it falls under non-maleficence. We need to remember the principle of double effect, which allows for an adverse outcome that is a side effect of the intended good outcome. So when you think of surgery, very rarely is somebody going to have surgery and have no pain or no physical immobility after surgery. The intent is not to cause pain to the patient. The intent is to do whatever the surgery is going to do to benefit the patient. But the pain is an unavoidable side effect. Along the same lines, deontology or Kantian ethics talks about due care and the standard to provide the most appropriate treatment with the least pain and suffering. We cannot always in healthcare 100% get rid of all pain. The idea is to minimize the pain as much as possible. Additionally, I wanted to note that harm is not just physical. Harm can be things such as infrastructure, management, and decision making. As managers, we need to be aware of causing harm through failure to supervise effectively, failure to staff effectively, failure to have the necessary resources available to our staff and patients. Regarding decision making, we need to consider financial decisions, and are we doing frivolous spending, or are we refusing to buy necessary equipment because we want to show in the budget that we have extra money at the end of the year? And are we making decisions that we're considering the impact on the community? So a lot of times you hear about this with things such as pollution and what type of output is your facility putting into that community. How are you disposing of sharps? How are you disposing of controlled substances that you're not adding risk to the community? And as I mentioned, harm can also be an act of omission, such as negligence or maleficence. Next, we're going to transition to beneficence, which was part of medical paternalism and remained within the Belmont principles. The foundation of beneficence comes from both Kantian ethics and utilitarianism. Beneficence focuses on first avoiding harm, then preventing harm, and finally eliminating harm. The idea is to maximize the benefits while minimizing the harm. So you have a duty, as in Kantian ethics, and you're maximizing benefits or utility, minimizing harm, as in utilitarianism. The definition of beneficence is a little bit more broad than just do good. Beneficence involves striving to help and a moral obligation to take steps to help others. Again, the connection to Kantianism. The purpose of beneficence is this idea that healthcare providers should embrace kindness and charity, and that they need to remember that the calling of being in healthcare is not about making money, but about making a difference for individual patients and minimizing harm to the patients, promoting patient safety, and minimizing pain and suffering. Historically, under medical paternalism and the Hippocratic Oath, the priority was beneficence. And it required that the patient and the physician agree that the physician knew what was best for the patient, that to maximize benefit and minimize harm, the patient had to follow the orders of the provider and not question them. As we move into the Belmont principles and we consider beneficence with autonomy, we now have a balancing act of honoring the rights of the patient as a competent, autonomous individual, but trusting the role of the provider who has extensive education and training in a specialized area. Beneficence under the Belmont principles actually brought about the concept of informed consent to help bring this connection between the patient and the provider, that the provider could explain the care and the rationale behind the care, and then the patient, based on that understanding, would agree to the care. The problem, though, occurs when the patient has the information and the understanding, but autonomously chooses to go against the professional judgment of the provider. And we kind of talked about this a bit with autonomy. And this is where the ethical dilemmas arise. Do we allow the patient to do whatever they want? Where is that line drawn? And you find in healthcare, there are some times where the patient makes unrealistic requests, often with pain management and desiring pain medication. And saying no to them is a violation of their autonomy, but it's also at the same time protecting them possibly from addiction and dependency. And so these are the kind of issues that we're going to get into over the next couple of weeks. Lastly, we're going to talk about justice, which also has a foundation in Kantian ethics. And it's founded in this idea that justice is the self-evident truth or duty. And justice opposes procedural equality, or equality only under the law. According to justice, all people should be treated equal because they are people. So we should not be using any people as means to an end. Justice includes the proper allocation of benefits and burdens in a society. How are we going to distribute resources appropriately? And we need to treat equals equally. The purpose of the principle of justice has to do with addressing the scarcity of so many facets of healthcare, whether that's the scarcity of human resources, whether it's the scarcity of material resources, whether it's the scarcity of financial resources, as well as respecting the rights of the individual, and that all individuals have a right to healthcare. They have a right to make autonomous choices, and they have the right to privacy. So if you remember, in medical paternalism, one of the 3 tenets was confidentiality. Confidentiality became absorbed in justice in the Belmont principles. Now, there are some allowable distinctions for justice under certain circumstances. There are times when not all people are equal. And I'm going to kind of go through the big examples. Experience. There may be times where there is a complicated procedure going on in healthcare, and we want the most experienced individual to be handling the case. It's not a time for a learning opportunity for a new person. And age can actually be an allowable distinction. There are certain medications or treatments that the very young or the very old may not be allowed to have. This could be because that there's not enough research and we want to protect the very young or the very old, or because of physical changes in their body that makes the risks outweigh the benefits. So, as we talked about, none of these principles in principlism is more important than the others. So when we're looking at justice, we're not forgetting about autonomy, beneficence, and non-maleficence. So we may look at deprivation. Who is the worst case scenario? And I'm an emergency room nurse by profession, and often it's the sickest patient that's going to get the most immediate care. We may look at distinctions based on competent. Who is the most competent to perform a task? Or look at distinctions based on merit. Who has earned the promotion? How do we distribute scarce resources? We can distribute scarce resources based on who needs the most, based on who is making the most effort towards rectifying the situation, or who's going to make the most effort to use the resource responsibly. The societal contributions that will come as a result of giving this resource. The merit, who's most qualified to receive a resource, or do we divide the resources equally among all? And again, you can see how when we start applying distinctions and distribution, we begin to be faced with ethical dilemmas. And we're going to look at procedural and distributive justice. And I talked about how justice isn't just procedural justice. Procedural justice is the idea of when you get your turn, you have the same treatment as everyone else, and that there's standards to make a decision fair. So procedural justice is justice under the law. But justice is more than just this. Justice under principlism, or the Belmont report, also includes distributive justice. How are we going to divide the burdens and benefits? How are we going to allocate resources at all levels, all the way down from, international levels to down to two patients sitting in the emergency room? And what are appropriate material reasons to discriminate, which we talked about. So procedural justice is basically like very cut and dry. This is the law. This is what we say. Distributive justice is a little bit more subjective and considers other factors. Just like we did with the ethical theories, we're going to look at how principlism answers the three big questions. First, ultimate reality, or where does truth and right and wrong come from? Under principlism, right and wrong should be based on the balance of autonomy, non-maleficence, beneficence, and justice. And when we are considering what is right and wrong, we need to remember that no one single principle should overrule another. All four principles are binding and should be considered with each other unless one of the principles becomes in conflict with our other duties. Human nature under principlism, or how do we behave as humans, is that we have an inherent dignity and worth. The emphasis here is on our individual freedoms and protecting the individual freedom that each person has, as well as recognizing that humans inherently will make choices based on their own best reason, their own values, their own goals, and their own priorities. The role of God in principlism is religious and philosophical neutrality. And principlism was developed in such a way that no particular religion or no particular philosophy should shape policy in a secular pluralistic society. Principlism was very secularized. And the concept here was that if something cannot be secularized, if something remains to be from a religious or spiritual background, then that something should be considered private and personal, and it is inappropriate to be part of social or public policy. So principlism allows for religion, allows for God, but says keep God out of public affairs. So, in conclusion, principlism is composed of 4 guiding principles that are to be treated equally. The first of those principles is autonomy, or the patient's right to choose, the patient's free will, which is guided by the concept of informed consent and the fact that the patient is fully aware of all aspects of their care. Non-maleficence, which is often referred to as the concept of do no harm. And this idea that harm does not only mean physical harm to the patient, but that harm can also occur of acts of commission, things that you do, or acts of omission, things that you fail to do, or negligence or neglect, where you are acting in a manner different than a reasonably prudent person with your same level of expertise and knowledge would act in a similar situation. And then beneficence, which is to do good and to try to minimize harm. And beneficence recognizes this idea of doing good first, trying to avoid harm, but that there are times where harm, such as pain, is unavoidable. But how can we minimize it to the greatest extent? And then finally, the concept of justice and the distribution of benefits and burdens. There's procedural justice, where everybody is given equal or the same, and distributive justice, which looks at reasons to discriminate and ways to allocate resources. Now, you may be wondering why we talked about all these other ethical theories before we discussed principlism, if principlism is considered the theory of bioethics. And there's a couple reasons, and that is because principlism is not without its own limits and faults. First off, one of the biggest challenges with principlism is that while all 4 principles are to be treated equally, often the principle of autonomy takes priority at the expense of the other principles. And there is this question that we need to remember, that principlism is patient-centered, and it was developed to protect research subjects. And we are now applying it in all areas of healthcare. And these are very simple, straightforward principles. Are they robust enough to handle the complex ethical dilemmas of bioethics and healthcare ethics? And I'm going to suggest to you that principlism on its own, just like any other ethical theory, is not without gaps and is not without its limitations. And as we proceed through this course, we're going to look at the critique of principlism and the attack on autonomy and why it is not appropriate in healthcare ethics to limit your ethical analysis to principlism. So those other ethical theories we discussed in class were not for nothing. We are going to circle back to them in just a little bit.